Good evening, respected Dr. Anuj Maheshwari, sir, Governor, ACP India Chapter, Dr. Amit Gupta, sir, Advisory Council Member, ACP India Chapter, respected guest speakers and fellow ACP members. I warmly welcome you all to this session of the ACP Case Files, a John Toker Evergreen Award-winning series. I now invite Dr. Niket Verma, who will be moderating today's session, to introduce the topics and speakers for today's events. Over to Dr. Niket.
Thank you so much, ma'am. Thank you, Dr. Anuj Maheshwari, sir, Dr. Amit Gupta, sir, and Dr. Preeti Dhot, ma'am, for giving me the opportunity to moderate today's session of ACP Case Files. A very good evening, everyone, and welcome to today's edition of the ACP Case Files. We are honored to be joined by our first speaker, Dr. Raman Puri. Sir is a senior intervention cardiologist who will be talking on case-based approach to lipid management, which is a very important and relevant topic in today's scenario, where we are observing a rise in dyslipidemia, especially among the younger population. As I said earlier, Sir is senior intervention cardiologist at the Cardiac Care Center in New Delhi. He is also the founder chairman of the Lipid Association of India. He has formerly been the head Department of Cardiology at Safdarjung Hospital and VMMC New Delhi, and is a member of the International Lipid Expert Panel and the IAS Regional Federation of the Asia Pacific. I now invite Dr. Raman Puri, sir, to start with today's session.
Dr. Niket, we also have Dr. Anuj Maheshwari with us.
Amit, now it should go like that, right?
Okay, sir.
We have started and we shall continue in the same manner, right?
My slides are visible, Amit?
Yes, sir.
So first of all, I'll thank Amit for giving me an opportunity to talk about guidelines for management of lipids in India. And I will, since most of the people here are endocrinologists and they practice endocrinology, so I'll talk more about diabetes in this presentation of mine. So these are the four important guidelines which most of us follow. Somebody follows European guidelines, someone American Diabetic Association, someone American Association of Clinical Endocrinology, and of course LAI is there as a front runner for the last 10 years. We started LAI in 2012. Now my cases will be four type of cases which you normally encounter in day-to-day practice. Like for example, case one is a 30-year-old male recently diagnosed with type 2 diabetes with no ASCVD risk factor. And these are the 5 ASCVD risk factors. And if you look into the lipid profile, LDL is 86, HDL is 41, TG is 155, total cholesterol is 160, and good control diabetes, blood pressure is 130/80. I think majority of you will say that we should not start treatment. We should go for a lifestyle intervention, and most of the guidelines will also be what you are saying. American Diabetic Association says no statins. European guidelines says keep LDL cholesterol target of 114 milligram. They classified it as a moderate risk group. And American Association of Clinical Endocrinology says that you should keep LDL cholesterol less than 100 milligram. But what Lipid Association of India says? Answer is you start the treatment even with LDL cholesterol of 86 and keep the LDL cholesterol of less than 70 milligram. They classify this patient as a high risk group. I'll justify what I'm recommending at present, giving you the recommendations. Now, second group of patient, which also is not uncommon, 36-year-old male with type 2 diabetes with history of hypertension. He has a history of smoking also. And if you look into the HDL, it's 35. So this patient has 3 major ASCVD risk factors. And so question comes that, would you like to treat this with statin? I think that someone of you will say yes to it. Majority will say no because LDL is 80 milligram. And if you say yes, then what should be the LDL cholesterol target? Now, according to American Diabetic Association, you give moderate intensity statin to this group of patients with lifestyle, intervention. European guidelines says that this patient belongs to high risk group, bring down LDL cholesterol to less than 70 milligram. American Association of Clinical Endocrinology says that very high risk group, LDL should be less than 70, and Lipid Association of India says the target, the patient belongs to a very high risk group, and the target of LDL cholesterol should be less than 50 milligram. Now, third group of patients is again very common, because about 25 to 30% of patients of coronary artery disease, they have a diabetes. So he's a 60-year-old male with type 2 diabetes and coronary artery disease, and he has no ASCVD risk factors. Only he's a diabetic and CAD. Now, question is that what should be the LDL cholesterol target? If you look into the American Diabetic Association recommendation, they say you start with high intensity statin. European guidelines says that this patient belongs to high risk group and bring down LDL cholesterol target to less than 55. American Association of Clinical Endocrinology says target of less than 55. LAI recommends LDL cholesterol less than 50, and they consider this patient as one of extreme risk group category A. And you can have an optional goal of LDL cholesterol at 30, which also will not be wrong. Now, the fourth group of patient is the diabetes who underwent, he has a coronary artery disease, who underwent CABG. He has a history of hypertension, had a stroke before, and he has a peripheral artery disease in the form of intermittent claudication of right leg. And if you look into the creatinine, he has CKD. Now, question comes, what should be the LDL cholesterol? Because he has 1, 2, 3, 4, 5, 6 clinical indicators with this patient. Now, American Diabetic Association says that you give high intensity statin plus ezetimibe plus PCSK9 if LDL cholesterol is more than 70 milligram. European guidelines says less than 55. American Association of Clinical Endocrinology says less than 55. Lipid Association of India says it should be less than 30 milligram per deciliter, and they classify this group of patients as an extreme risk group category B. And recently, National Lipid Association also has brought down the target. These are from United States, the target to less than or equal to 30 milligram, but they classify this patient as an extreme risk group. We all know that diabetic control is extremely important, but majority of patients, more than 70% of these patients, they die of cardiovascular disease. And if you look into the cardiovascular mortality in India, 25% of infarctions are in less than 40 years and 50% are less than 50 years. If you look into all trials of coronary artery disease, about 25 to 30% of these patients are diabetic, and the mortality is higher in those patients who have CAD plus diabetes if you compare it with CAD without diabetes. Now, question comes, why we differ from other international guidelines? But we have a unique features which is different from Western population. Our age of onset of diabetes is somewhere around 25 to 34 years, which is about 10 to 20 years earlier than the Western population. And we have a highest prevalence of diabetes. This is based on a multinational study, and this peak of this prevalence is also 10 years earlier than the Chinese and Japanese individual. And if you look into the process of atherosclerosis before the patient manifests diabetes, he has already the atherogenesis has started. There is already an evidence of subclinical atherosclerosis, and this will be clear from this 10-year history of cardiovascular incidence. You can see that those patients with impaired fasting glucose, they have 29% higher CVD events and 42% higher CSD events as compared to those patients who have normal fasting glucose. And metabolic syndrome is not uncommon. You see it quite frequently in your day-to-day practice. If all 5 components of metabolic syndromes are present, then you have 6 to 7 times higher CVD events as compared to those patients who have no metabolic syndrome. This means these all diseases, impaired fasting glucose and metabolic syndrome, finally leads to the diabetes. So this means these patients who becomes diabetic, they already have a very high incidence of coronary artery disease and CVD events. Even Chennai urban population study says that 15% of patients of impaired fasting glucose have coronary artery disease. So based upon all these factors, and there is another trial, CINTI-2 trial from India only, which shows that at the day of onset, means you diagnose diabetes, there is very high prevalence of ASCVD risk factors. And you know that these ASCVD risk factors, they are responsible for initiating atherosclerosis, and also they are responsible for progression of atherosclerosis. So based upon all these things, what LAI says that you have to be aggressive, because we have a very aggressive coronary artery disease. Many of our patients of CAD had diabetes, so they die because of their high chances of dying from coronary artery disease. Therefore, the day you diagnose diabetes, you should start treatment of diabetic dyslipidemia because, or dyslipidemia, I will not say diabetic dyslipidemia, because already process of atherosclerosis has already been started, because atherogenic dyslipidemia, which is, as you have said, that LDL was 86, which looks to be a normal. So normal looking LDL cholesterol with high triglyceride and low HDL is what is called atherogenic dyslipidemia. And LDL, though looks normal, but there is increased prevalence of small dense LDL particles, which are said to be highly atherogenic. And therefore, we are strongly in favor that we should bring down the LDL, treat the diabetes, the dyslipidemia, the day you diagnose diabetes. And maybe in future publication of ours, we will say that you should diagnose, you should treat even in patient with impaired fasting glucose and also patient with metabolic syndrome. And you have to make sure that you have a good glycemic control and also all other modifiable risk factors are taken care of. Now, the patient is diagnosed diabetes. Now, what happens in the first 2 years? 15% of these patients have CVD. So this means this CVD, which has manifest after within 2 years after onset of diabetes, is not of 2 years duration. It is of 15 years duration at least. And if you look into the mortality, less than 5 years, about 1.5 times more mortality as compared to non-diabetic. This cannot be a matter of 5 years. It is a matter of about 10 to 15 years. That is what exactly we want to say, that you should be very, very aggressive in treating dyslipidemia, because majority of these patients are dying because will die of cardiovascular disease, and dyslipidemia plays a very important role. Based upon inter-heart study, the population attributable risk is about 50% out of 9 modifiable risk factors. Now, treating dyslipidemia with statin is going to reduce cardiovascular event. We have number of trials, primary prevention trial like FCAP trial and heart protection study shows there is a significant CV risk reduction. And of course, the CARDS trial was one of the only trials, because after that, it was such a wonderful trial showing a remarkable reduction in event that it was stopped prematurely. Then remember one thing, that at any level of baseline LDL cholesterol, if you reduce LDL cholesterol by 40 milligrams, you are going to reduce cardiovascular event by 22%. And if you reduce LDL cholesterol further by 20%, you are going to reduce it further by 16%. So even whatever level of LDL cholesterol you are going to do. Now, for example, American Diabetic Association says, European guidelines says 114. And I reduce from 114, 40 milligrams, so it becomes about 74. So if I bring down LDL from 114 to 74, I am going to reduce events by 22%. And this 22% is extremely important for Indian population, because we die from cardiovascular events much higher than Americans. We develop coronary artery disease 10 years earlier than Americans. So based upon this, Ali, I thought that why not to have our own recommendation. There are no doubt that American guidelines are good for Americans. European guidelines are good for Europeans. They are wonderful guidelines, but they are applicable to their own population. So we had number of meetings, and we came out with an expert consensus statement. And this is the summary of, I'll give you the summary, and in case time permits, I'll go for further justification. Now the primary target is LDL cholesterol. Co-primary target is non-HDL cholesterol, and secondary target is ApoB. Now, when a patient comes to, diabetic patient comes to you, find out whether does he have underlying ASCVD or no ASCVD. And if there is no ASCVD, whether there is a target organ damage or no ASCVD risk factor, then this patient belongs to high risk group. That is what was our case number 1. And if the patient of diabetes without ASCVD has 2 or more ASCVD risk factor, or target organ damage, he falls into very high risk group. The LDL cholesterol goal is less than 50. And this was our target case number 2. And those patients with diabetes and ASCVD, if they have 1 or no ASCVD risk factor, or they have no target organ damage, they are classified as extreme risk group category A. And that was our case number 3. And case number 4 was are patients of diabetes with multiple comorbidity. So that is the category B of our, these are the 4 cases which I discussed with you. Now comes to the, question comes that how you are going to bring down LDL cholesterol to 30 milligram if required. Answer is very clear. You know what is the baseline LDL cholesterol, then you know what is the target LDL cholesterol level, then you know what is the percentage reduction of LDL cholesterol required. And you know that moderate intensity statin reduces LDL by 30%, high intensity statin plus azithromycin reduces by 65%. If you require additional LDL cholesterol lowering, by about 20%, you can add bempedoic acid or bile acid sequestrant. If it is more than 20%, then PCSK9 can be considered, and especially if lipoprotein small a is raised, it should be a drug of choice. Now, question comes that how you are going to proceed, how you are going to treat your patients based upon earlier recommendations. You have classified the patients, you send blood sample, which should include lipid profile plus ApoB and lipoprotein small a. Those patients with high risk group, you start with moderate intensive statin or high intensive statin because the target is higher, it is less than 70. Whereas in those patients with very high risk group, extreme risk group category A and B, you should always start your patient on high intensity statin plus ezetimibe if the fibrate is start fibrate if the triglyceride is more than 500 milligrams. Now repeat lipid profile after 4 weeks. If the target has been achieved of LDL, non-HDL and ApoB, then continue same treatment. And if, for example, it is not achieved, then you can add another drug which was not started earlier, like bempedoic acid or PCSK9 in both the groups, if depending upon what percentage of LDL cholesterol reduction is required. Repeat, always try to achieve LDL cholesterol target first. ApoB and non-HDL comes later. So after 8 weeks of this treatment, if I assure you that all of your patients will achieve the LDL cholesterol target, and if, for example, the non-HDL and ApoB is still not achieved and patient was on fibrate, which we started on day 1, then you can always add eicosapent ester in that patient and repeat lipid profile after 12 weeks and see whether the targets have been achieved or not. Most important part is this, that you achieve LDL cholesterol with statin and non-statin drug, and try to achieve non-HDL and ApoB with fibrate first and eicosapent ester next. But remember, you have to treat all modifiable risk factor, and glycemic HbA1c control is extremely important, because if it is not controlled, you will not be able to bring down the triglyceride, you will not be able to achieve non-HDL cholesterol goal and ApoB goal. So these are the summary of this, and depending upon time, I'll give you the justification of these recommendations. Now coming to the extreme risk group category. Now remember one thing, at any level of LDL cholesterol, those patients of diabetes associated with coronary artery disease, they have more events as compared to those patients of coronary artery disease without diabetes. Now, and second, if someone has diabetes and coronary artery disease, the events will be less than those patients who have diabetes, coronary artery disease, and other morbidities. So these are the two important, we have a strong scientific evidence for these two important statements. Now, in IMPROVE-IT trial, you can see that we achieved LDL cholesterol of 53. This was the mean LDL cholesterol achieved. You can see the patients of CAD and diabetes, which is in a yellow line, they have more events as compared to those patients of CAD, which doesn't have diabetes. And if you look into the absolute risk reduction of 5.5 with diabetes and 0.7% with non-diabetic. So that shows that even at achieved LDL cholesterol of 53, those patients of CAD and diabetes, they had more event as compared to those patients of CAD without diabetes. And even in FOURIER trial, where median LDL cholesterol achieved was 30 milligrams, those patients of diabetes, they had 14.4% event as compared to those patients who didn't have diabetes, and the event was only 11.4%. They had diabetic patient has 3 times more event as compared to the non-diabetic patients. Now, regarding second statement, if you look into the IMPROVE trial further, the CAD patient had residual risk of 30%, which went up to 40% when there was diabetes, and it went up to 56% when there was peripheral artery disease. So this means, what I want to say, that all patients of CAD and diabetes cannot be grouped in one category. You have to see what are the other comorbidities present that will define what should be the target which you should achieve in this patient to reduce future cardiovascular event. This is again a trial which shows that patients of CAD, diabetes, and hypertension, they had maximum in-hospital outcome, 6 months outcome and 12-month outcome as compared to patient with CAD, and also as compared to patient with CAD and diabetes. So this is the basis of our extreme risk group, category A and category B. And these are the basis for lower LDL cholesterol in patient with category B. Now coming to justification of goal of less than 30 milligram, if you reduce LDL cholesterol by 40, I said you reduce event by 22%. If you reduce LDL cholesterol by 20 milligram, you reduce 13% coronary death or non-fatal myocardial infarction. So our target of LDL cholesterol is less than 50 milligram in patients with coronary artery disease. So if I reduce, by 20, so mine's from 50 to 30, I expect these benefit which is there on the screen at present. So that is one of the reason hypothesis which was in our mind when we came to the level of 30. But most important trial which gave us the main strength was the 4-year trial in which the achieved LDL cholesterol was 30 milligram and there was 50% reduction in events. And in this trial, 2% of patients achieved LDL cholesterol less than 10 milligram with a median of 7 milligram, and there was evidence of reduction in even at that level of 7 milligram median. So this means there is no lower level of LDL cholesterol in which benefit is not seen. Then there are some post-hoc analysis. I'm not going to go into detail, which shows that lowering LDL cholesterol less than 30 milligram reduces event. Then 1 year later, then our recommendation, even the National Lipid Association also came out with a statement which also recommended LDL cholesterol less than 30 milligram in patients with diabetes and coronary artery disease. Now, question comes that even in 14.4% of the patients of diabetes had event despite LDL cholesterol of 30 milligrams. So this means we have to look beyond LDL cholesterol when we have to reduce this 14.4% events, and therefore triglyceride, non-HDL and lipoprotein small a is also to be taken into mind. And triglyceride, the question comes, should we treat? Answer is yes, because those patients of TG more than 204 and HDL of less than 34, there is 35% reduction in event when fibrate was given. Though all fibrate trials were said to be a neutral trial or negative trial because there was no significant reduction in primary event, but we still recommend it it's an important drug. Pemafibrate trial has not been continued because of infertility, but of course we have a reason why it is like that. Icosapent ethyl ester have shown that diabetes with one or more risk factor, there is significant reduction in event. So preferably keep the triglyceride of your patient to less than 100 milligram and non-HDL LDL cholesterol target plus 30 milligram. ApoB is extremely important in patients with diabetes, metabolic syndrome, obesity, and it becomes more important if there is a patient who is in extreme risk group. And these are some of the important. It's an important slide which shows that how LAI recommendations differ from other international recommendations. So these are the points which are already there in our publications. So take-home message is that initiate statin on the day diabetes is diagnosed. Decide diabetic patients ASCVD risk category and achieve LDL-C, non-HDL-C and ApoB target as at earliest as recommended by LAI. Screen Indians for diabetes, pre-diabetes, another ASCVD risk factor including lipid profile. Remember, LAI have strongly recommended that age 20, when you are going for a standard lipid profile, you should include lipoprotein small a and ApoB at that age. Good glycemic control in addition to lipid-lowering drug is important to achieve lipoprotein targets. Lifestyle intervention is very important and treat all modifiable risk factors as per respective guidelines. Thank you very much for your kind attention.
Thank you very much, Raman sir, for the very enlightening talk. Before we move on to the questions, I would like to invite comments from Dr. Anuj Maheshwari sir, who is Governor of the ACP India Chapter.
Sorry to say that this talk was not in the format of the program. So this is really very disheartening to me towards Amit Gupta. Amit Gupta has promised to me that he will make sure that this should remain in the format of the program. Dr. Raman Puri is a very nice speaker. We have heard him multiple times, and this talk has also been heard by all of us multiple times. But this program is especially designed for the early career physicians so that we can fulfill their demands as per the very specific format. So I think Amit Gupta should have ensured it that this program should be in the same spirit and same format of the program. But anyway, whatever has happened. Now I will request our moderator to open the sessions for the question and answer.
Thank you, sir. Raman sir, there were questions regarding the use of bempedoic acid, whether there is any role of bempedoic acid also for lowering LDL cholesterol levels, as well as if there are any guidelines from the Lipid Association of India regarding the use of bempedoic acid.
First of all, I'll answer Anuj Maheshwari's comment regarding the presentation. No doubt that it's a different type of presentation, but I think this is very important for those who are entering into practice and starting treating dyslipidemia, because we have a very wrong concept of not giving statin or treating dyslipidemia from the very beginning. So the message is extremely important. Targets are extremely important. Unfortunately, not to say that the beginner doesn't know about it. Even those who are said to be an expert, even they don't know about the targets and how to treat active dyslipidemia. Now, coming back to your Verma, Niket, that bempedoic acid should only be reserved in those patients in which you are not able to achieve LDL cholesterol target by high intensity statin plus ezetimibe. Remember one thing, until unless patient has statin intolerance. If the patient has statin intolerance, there is no question of giving high intensity statin, though in the trials of bempedoic acid, mild dose of statin has been given because it does reduces LDL cholesterol by 25 to 30%. And second is that you should only add bempedoic acid if you require additional 20% LDL cholesterol lowering. If you require greater reduction in LDL cholesterol lowering, then probably you have to consider PCSK9 inhibitor. So in our statement, which was published about 7 months before on bempedoic acid, we have clearly shown, given the step 1, step 2, step 3, step 4, how we should start bempedoic acid and where bempedoic acid should enter. That's very important for us. And remember, when you are giving bempedoic acid, make sure that his uric acid level is being done, because it goes up and patient can have gout. And therefore, if uric acid is on the higher side, you should give a uricosuric drug when you are going to treat this patient.
Thank you, sir. Dr. Purvi Chawla has raised her hand. Ma'am, please.
Good evening, all. If I have the permission of the governor, I just have one question. I know we are talking about statins and LDL here, but I just want to know if you have any experience with bempedoic acid and triglycerides, because that also remains an issue with our Indian patients. And sometimes we are struggling even with multiple drugs. We're just not able to get triglycerides under control. What is your comment on that, sir?
First thing, that bempedoic acid does reduces LDL, does reduces non-HDL, does reduces ApoB, but it does not reduces triglyceride. Remember one thing very clearly. It doesn't reduce triglyceride, number one. And when you are treating dyslipidemia, whether it's a diabetic dyslipidemia or anything, your target should only include LDL cholesterol as first and non-HDL cholesterol as 2. Why? Triglyceride should not be a part of your treatment protocol, and ApoB the third. Why I'm saying is that once you control non-HDL cholesterol, automatically triglyceride will come down. What exactly is non-HDL cholesterol? Is the cholesterol content of a triglyceride-rich lipoprotein. Therefore, it is important that you should stick to non-HDL cholesterol target, LDL cholesterol target, and ApoB target. That is extremely important for you. Once you do it, now, for example, if somebody has a primary hypertriglyceridemia, you may whatever do, the triglyceride may not come down. But in primary hypertriglyceridemia, they do not cause atherogenesis because they are more dangerous to cause pancreatitis, because these are a large triglyceride particle which doesn't go into the subintimal space. Very clearly, LDL cholesterol target as a primary target, non-HDL number 2, and ApoB, if possible, if somebody can afford it, ApoB as a third party.
Thank you so much, sir.
Thank you, sir. Dr. J.K. Sharma, sir, wants to ask a question.
I think we should be very much sticking of the time. Dr. J.K. Sharma, you must ask your question, and I request Dr. Puri to give the answer in brief, because we are going to have another session waiting.
Sir,
Yes.
thank you, sir. A very brief question. In uncontrolled diabetic patients, when the triglyceride levels are up to 300, we usually don't treat the triglycerides, because once the sugars are under control and when we start with statins, that also brings down to some extent. So what do you say? We should start right from the beginning, or we should wait for the sugars to be under control?
I think that statin is the treatment number 1, lifestyle intervention number 2, proper control of diabetes is number 3. If after that you are not able to achieve LDL triglyceride less than 150, forget about triglyceride, non-HDL, then you should start fibrate if required.
Thank you, sir. Thank you.
Thank you. Thank you very much.
Thank you so much once again, Dr. Raman, sir. Now we'll move on to the next session for today. we have a question answer session, which will be conducted by Dr. Anuj Maheshwari sir and Dr. Vidya Sundaresan. And the topic is mentorship for ECPs, how and why. Can we please have the CV slide of Anuj sir on the screen?
Yeah. Dr. Niket, now I will take it forward. Thank you very much for the nice moderation.
Thank you.
My greetings to all ACP members and all those who are attending this program. And this program is actually being designed to help more and more ACP members, especially those who are in their early career phase, to help them in the case file format, which has been very well started with the ideas of myself as well as Amit. And we together has implemented this, and this ultimately this program has won the John Tucker Evergreen Award also. So I wish that this program should remain continue in the same spirit. The second part of the program is always remaining in a different pattern and different way, in which we ask and we talk to some person who has experienced all those nitty-gritties which are coming in the life of a early career physician. Like we have already discussed the issues of the financial planning. We have already discussed the issues related to insurance, as well as indemnity, professional indemnity, as well as we have also discussed the management of the funds, management of the time, as well as we also discussed in the past about the medico-legal issues in this program. But today we thought that we should discuss the aspects of the mentorship. And this mentorship is a thing which has not been actually recently introduced to our country. India has been witnessing the mentorship kind of the things for a very long. We had a great history of the mentorship. Today, we are having a person who is not only a governor of Illinois chapter of the American College of Physicians, but she has done her basic education till the post-graduation in India. And after that, she went to America and she settled there. And she has been knowing the difference of the concept what we follow in our tradition and what is the concept is being given by the American College of Physicians about the mentorship. And probably we shall be talking her about the newer things which has been entered into this concept and what are the legacies which are being followed by American College of Physicians, which were also being followed by us also in due course of the time. And she is none other than very well known and very nice personality, Dr. Vidya Sundaresan. Dr. Vidya Sundaresan, we welcome you here in this program, and it is really our proud privilege that you are joining this program. And also you helped the India chapter at multiple forums, at multiple ways. Dr. Srinivas Murthy is also there with the mask on the face, so probably you may not be recognizing him, but he is a very good friend of you, and most of the time he praises you a lot. So being a senior and being alumni of the same college from which you have been there. So with these pleasant memories, we shall come over to the topic, because we also have only 30 minutes to have this discussion. So Dr. Vidya Sundaresan would like to formally introduce you before we start the talk. We'll request the RX events people to show the Dr. Vidya's introduction slides. Do we have Dr. Vidya's introduction slide? Yes. Dr. Vidya is an infectious disease specialist. She is a medical advisor to Sangamon Country Department of the Public Health Infectious Disease. She is based at the Illinois, as well as she is governor of the Illinois chapter of American College of Physicians. And apart from this, multiple credentials are associated with Dr. Vidya Sundaresan, which are time is not enough to discuss and to elaborate all of them. With this small introduction, we are coming over to our topic. And today's first thing what comes to my mind, as I already said in my introductory remark, that what is the ACP concept of mentorship? Is it the same what we have followed in our traditions, or is it something different? Over to Vidya.
Yeah, first of all, thank you, Dr. Maheshwari, for all these wonderful opportunities, and it's always a pleasure to connect with you and have this opportunity to come and talk to early career faculty of physicians as well as other physicians in India. So it's really an honor for me to be invited back. So coming to your question, I'd like to start off with three important words: mentorship, sponsorship, advocacy, or allyship. There are differences in these, and ACP actually can help with all of these. So mentorship would essentially mean that you have an advisor or a guide who is a little bit older and more experienced than the phase that you're in. And ACP has, in 2021 December, they in fact introduced a program specifically for mentorship, and very well defining what mentees should kind of try to emulate, what mentors should try to emulate. So that we have through the mentor resource library. You can actually search, and it's free of cost, available with all these resources for mentors and mentees. The second word that I mentioned was sponsorship. So sponsorship is when you have a strong advocate who will help you with your career goals, put you in places you need to be, help you network. So this is somebody that is already in a situation or a position where you want to be in a few years, and they find you valuable, so they can be your sponsors. So having mentors, a mentor can also be a sponsor. A sponsorship through ACP is also a great way of networking and finding sponsors. The last is allyship or advocacy, and this is with near peers. So people who are your peers, people who are closer to you in your career, in your trajectory of your career, they can actually help you in terms of looking at your work, reviewing your work, what you're doing. Is it good? Is it good enough? They'll give you honest feedback of people who you trust, people who trust you, and would not hesitate to advocate for you, saying, this is my friend, this person I can endorse. So that would be an ally or a near peer mentor. So these are the three things that ACP definitely has been trying to put in place. In December 2021, they started this program with a lot of resources that are available online.
Yes, thank you for this elaborated concept, and it's really advancement of the earlier what we were following. And would like to say in this sponsorship and choosing the mentors and mentee, how does the ACP could be helpful?
Yeah. So, I think as an early career physician, we need to understand first what our needs are. So let's say they give a very nice example of a doctor who is an MD PhD. On the website, there is, again, the mentorship resource library has multiple examples. So you can actually listen to that in detail as well. So let's say there is a physician who's an MD PhD. They don't have any grant writing skills, or they've never written a grant. They do have skills, but they've never really written a grant. And let's say they are not optimized in the area of immunology, and they want to seek out a mentor who's excellent in that area and who can guide them in writing a grant. So there are, mentors available, PubMed searches, or just online searches, people who are geographically closer to you that you can meet, or people who have achieved a lot in the area that you want to really achieve in, reaching out to them, making the first contact through email is not a bad idea. So email is now acceptable. But sometimes in meetings, when you attend meetings, you can seek out a person directly in person as well and say, very respectfully, introducing yourself and then say, "Do you have time for me?" So emails are a good way of reaching out. And once you reach out, that can be considered as a first contact. And then, most of the people, remember, mentorship, a lot of the people do out of goodwill. They don't, they do it because as mentors learn as well. And when they are mentoring you, they do it, their time is free, basically. So you want to be very, very respectful to that. And then they will tell you whether they will be willing to take you on as a mentor or not. So first introduction paragraph, who you are, what you seek, very, very clearly. And then would you have time to talk to me about this? And set up a meeting, 15-minute meeting, and then see if this person who is willing to mentor would be able to mentor you or not. So there are different ways of doing this. And again, the resource library points to those. Making a contact and being respectful of people's time is critical.
If we are in same country, it is very easy to get the things organized. But suppose if we are sitting in a different country like India, and I want, and some of the early career physicians want to choose a mentor from who is sitting in the US. So is it possible to do overseas, or you think that it is mandatory to remain at the same work so that we should meet each other and we should have some discussion? So now in advancement of the technology, in the words of the internet, in the words of this Zoom kind of the facilities, can we move on to the overseas mentorship in which we don't need to be staying at the same place?
Absolutely. I think one thing that COVID has helped us with is electronically, we are a global village now, and connecting with people has become so much easier. So definitely it's possible. I have mentors who are not geographically in the same place, and I meet with them on Zoom many times. So yes, it's absolutely possible. I will give you an example. When I was an early career faculty, I joined SIU School of Medicine. This is a smaller medical school, relatively newer medical school. We're only about 45 years old as compared to some institutions which are really, really old. So when I came here, my chair of medicine, when I had my first meeting, told me that I want research is a priority for me. So I actually laid it out to my boss, and I said, research is a priority. I have a mentor in infectious diseases, but there are other things that I may need. And in fact, my chair identified. He said, okay, your mentor's an expert in this areas. If you need expertise in this area, our school is willing to help you find a mentor outside of the institution. And then, we will be able to help you out. Luckily for me, my mentor, my immediate boss in infectious diseases is actually phenomenal, an all-rounder. So I got lucky. I didn't need any external mentors, but the chair of medicine did offer that to me. So, ask in your institutions, sometimes they have a grant or a small, financial incentive set aside for people who are willing to mentor. And a lot of times there are, contracts and things like that, which you can have in place. Even if it's not financial, there may be, some collaborative contract that exists between two universities or two institutions, which you can definitely avail of.
Yes. Can we elaborate it here that what are those areas in which a mentor can help its mentees apart from academics and research? So a person who is sitting in some small town of the Chhattisgarh in India is getting the mentorship of Dr. Vidya Sundaresan from Illinois. So how can he be benefited? What are the areas in which he can be benefited?
Absolutely. So, a mentorship is important at every stage of our lives. I want to definitely emphasize that. In every stage, doesn't matter where you are in life, you can always learn more. You have to be open-minded. You have to be curious. Never let that curiosity go. So, mentorship will definitely help. And when you are mentoring, you realize when you are, in a stage of your life, when you mentor, you learn a lot. I learn from my students, I learn from my residents, I learn from my fellows, my peers, and of course, my mentors. So, there are opportunities to learn at all times. What are the things we can learn? So definitely, content expertise. As you grow in your life, you want to become a content expertise. And I tell my early career faculty when they join, the first 5 years are formative. After you graduate from medical school, the first 5 years, you define your style. You've been trained by many attending physicians or many people that have been important operative during the time that you were training. But the first 5 years, you develop your style. So that's content expertise. You read. You are just honing in your style. But at the same time, for our early career faculty, we also start leadership very early. In fact, I am involved in the medical school. So medical students too, we're trying to have courses for leadership for medical students as early as second year of medical school. So leadership, and again, research skills, if you're interested in research skills, and all the other things that you were talking about earlier too, finance and medical legal, all those things you need to know about. And the areas where you are not comfortable about, seek out help. So definitely that's possible. But I think for career development, content expertise, and different skills of leadership, which include negotiation. How do you negotiate with others? How do you communicate well with others? All these are things that you absolutely need a lot of guidance on.
Yeah, very nice. So in nutshell, we can say that mentorship brings a complete package for the life in which you can take the help of all corners of the your academic or your professional field, and especially if you are in medical science, then you can be a very good leader. If your mentor is good, you can be very good academician, you can be very good researcher. And these things actually I felt in my life also, when I got a very good mentor whom I was admiring a lot, and he helped me on every step of the life. He showed me a very important things and very small nitty-gritties wherever a person does a mistake. So these are the beneficial parts what we get from a mentor. And you very rightly said that it is not only a one-way traffic. You get the benefited even as mentor if your mentee is good enough, your mentee is brilliant, your mentee is upcoming star, then definitely you get the benefit. And what I understand that every person, even if your mentee is not a very bright student, even he is normal person, still you can get, because every individual is very much different, and you learn from each and every person whom you are getting connected for some time. So as a mentor, it is you to decide how much your capability to grasp is there, and how much your antennas are open to receive what you are getting from others. So these things are beneficial from the mentor side also. But very important thing I would like to have your opinion about that, that whenever we choose a person as a mentor, or whenever we accept a request from a mentee, once a person is on the height of its career, a lot of people wants to make him mentor. Now this becomes a very difficult for a person how to choose his mentee. Should we accept all requests which are coming for mentorship, or we should have some choice? And if there is some choice, then how should we choose them?
Sure. That's a great question. So, time is limited for all of us. We want to make the most of it, right? And then
We have 10 minutes.
Yeah. Yeah. Well, I mean, in general, time is, we have just limited time. So we also want to make the most of, what we have. We're pulled in so many different directions. we want to achieve clinically, you want to achieve research-wise, you want to publish. There are so many things that you want to do, right? So it's very important to be very clear on what your priorities are. So, a self-assessment, start out with a self-assessment, whether you're a mentor or a mentee. I think it really helps. For me, my mentor tells me to do this, periodically, every 2 months or so. I make a list of what to do and a don't list, what to take off your list. Okay, so those things really help. So I think you need to assess your priorities. And then for a mentor, when requests come, I feel that a good mentor would take care of these things. First of all, look at your own time. So if you have time to accept that request, if you think that mentor-mentee match is going to be beneficial for the mentee, and then also good use of your time. So you use that, look at that to see if that would be a good match. Let's say it's not a good match. Then a person who's a good mentor would also say, I'm sorry, I do not have time for this, but here is a person who can do this for you. So also give some suggestions on, let's say, I have students asking all the time, would you be able to mentor me for this? Would you be able to mentor me for that? I don't have time for that. But what I would say is, I do not have time for this, but yes, I have, Dr. Wakar or, Dr. Prakash, somebody else that's there. They would be able to mentor you for this particular thing. Say there is something I'm not an expert at, somebody else may be an expert at. So I can definitely guide them or point them in the right direction. And sometimes I even write an email. Let's say one of my colleagues is good at a certain in a certain area, and may be able to accept this person as a mentee. So I would just send an email saying, hey, this person wants to connect. Would you be able to do that? And CC the person who had asked me for that as well. So establish those connections. And then you don't want to close the doors. There are some opportunities you don't want to close the doors. So Dr. Archana Chatterjee would always say this. She's Dean of Rosalind Franklin here, but I've heard her talk. She would say, if you cannot do something, say, I'm sorry, I won't be able to do it. Find a person who can do it at that time. And the third thing you do is, and the next time, if you have anything that I can help you with, don't hesitate to reach out. So you give the reassurance. So those are the 3 ways to make sure that you're honoring the mentee as well as honoring your own time. Dr. Maheshwari, I think you're muted.
Sorry. So now the important thing, what I am going to ask you, the area of the expectations. Expectation from a side of the mentor, many of the time. Is it really necessary for a mentee to live up to the expectations of the mentor, or is it not really needed? And there is a difference between the expectation, very thin line between the expectation and being demanding. So how can we differentiate and how can we respond such kind of the things when we are coming to this kind of the relationship?
Yes, I think, that's a great question. A key for a good mentor-mentee relationship is mutual respect. You have to be respectful of your mentor's time. So you have to be prepared when you're going for a meeting. You have to be very well prepared as to how you're going to utilize that time. Let's say I have a 30-minute meeting. I took over as chief of infectious diseases a few years ago. And I identified a mentor who could help me navigate the process of, being a new chief. And I would have a monthly meeting with her for 30 minutes. I knew I had her for 30 minutes, very valuable time. So I would actually make an agenda, get ready with everything that she needs. You also want to know the mentor style. For instance, I have a very short attention span. So if my mentees give me pages and pages and pages to read before they come, I don't do a good job of it. I don't have time to go through all that. So if my mentee comes with me with very specific questions, 1, 2, 3, 4, and then I'm able to immediately answer those, that helps. So you assess your mentor's style. And so, you want to be respectful. It's not, you ask, would you prefer this? you observe how the mentor is helping you. So all these things will help you optimize the time. So it's very, 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 very important to be respectful. And that really leads to a good relationship between the mentor and mentee. You get the best out of the mentor at that time too. So I would tell the mentors to be extremely prepared when you're doing that. And also in terms of expectations, like you're saying, Dr. Maheshwari, very, very important. It's very important to set the expectations right in the beginning, in the beginning of having that, going on that path of mentor-mentee relationship. Just say that this is, mentor also should clearly give expectations, and mentees should also seek those. Would you be able to do this? And, to have that clear conversation definitely is helpful.
Yes. For example, I have seen multiple times it happens that a person got the mentorship from a very heightened personality of the world or country, and then he starts using his name for his own upliftment. That I know him very well, and he's I can get any of your work from him, and this the kind of the thing. So how should we handle these kinds of the issue as a mentor also?
Yeah, it's very important to be ethical whenever we are doing anything. I think respect, being ethical, is definitely something that should be the top of your goals in life in general. So you can get a lot more done by being respectful of the person, especially when they have agreed to help you. A lot of them don't take any money. It's just out of the goodness of their heart. They're, giving you time. I have so many mentors who, just give me that half an hour a month or whatever I ask for, just out of the goodness of their heart. So I am very grateful. So I think gratitude, respect, and being ethical, these are some of the top priorities for any relationship, especially when you have a mentor-mentee. And it's very important to be mindful of being honest, and not use anybody's name for a bad purpose. So definitely, when it helps you, to network and things like that, yes, that's the whole purpose. You want to network, but you have to be ethical and honest in how you use someone's name.
Sometimes it happens that I have asked someone to become my mentor, but after some time I could know that we are not working on the same page. And what I was really thinking about the personality whom I chose as a mentor, it's not working in that direction. The things are not working up to the expectation of both the sides, maybe mostly from the mentor side, because mostly from the mentee side. Because once it is from the mentor side, very easily he can say, I don't have time, I don't fulfill your request, and I don't know about what you are asking. But from a mentee side, it becomes very difficult how to get rid from a person who he has already chosen as a mentor, but now he thinks that things are not working. So what should be the amicable way through which the things can get settled here?
Yeah, I think one thing that's different through the ages, and I would say the Generation Z and the younger millennials who are now are very clear and open in conversing and conveying things. I used to be very scared when I was a early career faculty to say anything or speak my mind. But that freedom is there. I think a lot of them are confident, and if you're honest, there's nothing to be scared about. And I think you should try to see where exactly that malalignment is in the expectations, or whether it's goals or whatever it is. You want to just see where that malalignment is. And there's nothing wrong in saying, I think I would need more time in this, and if I understand that you're busy, would it be possible for you to point me in the direction of someone else who can help me? Or you can do that yourself, identify someone else who can probably identify who can help you better in that area, and say, I found this person who may be a better match for this particular area. You have helped me so much in this. But for this area, I was wondering what your thoughts are if I seek out help from someone else. And I know you're time pressed, but if I seek out help from someone else in this area, how are you going to feel about it? So there's a respectful way of doing this. And being honest about it, and communicate. You can't do things behind someone's back. So if you're switching or doing something, communicate. That definitely leaves the doors open. You're not shutting any door and causing bad blood. So those things are very important.
Thank you, Dr. Vidya. We are nearly completing our time, which has been allotted to us for this discussion. And you have really taken up very tricky questions of mine, and which I was really finding, even for myself, to answer difficult. Dr. J.K. Sharma, who is our Vice President of the Council of India Chapter, is on the screen. Dr. Amit Gupta, he is a very bright person of our council, and he is associated with multiple very important activities in our chapter, like early career physicians. He is associated with the IRIS project, and he is the person who is behind so many things and silently works for multiple projects, sometimes with the ACP, sometimes for RSSDI, but he is a multifaceted personality. Dr. Preeti, he is the person who has conceptualized today's program, and both the programs has been decided by her to keep, and she is professor at AIMS Batinda, and she is medicine expert, and many other people, those who are hiding their so they can come up, and I would like to meet them. Dr. Vidya, you know very well Srinivas Murthy. Dr. Niket Verma was the moderator of the day. He is also the faculty at AIMS. Dr. Purvi Chawla is our early career physician ECP council member, and she is also very much bright personality, as well as she is multifaceted personality working on multiple forums together, and she has been displayed this time, this month's Femina also. So I know you must have gone through the Femina when you were in India, because you have also remained in Delhi also for some time. And even in Bangalore, you must have gone through the Femina, and she has been on the cover page of the Femina this month's Femina, if I am not wrong, Purvi?
Yes, sir.
Yeah. And Dr. Srinivas Murthy, you know very well. Dr. Ashish is there. And many people, those who are behind the screen. So these are our council members. I especially requested all my council members to remain there to welcome you on this program, today's program. And good thing to tell you all that Dr. Vidya Sundaresan is coming to India in this month only. Coming month means coming the March. On 23rd and 24th March, we are inviting her on the G20 Youth Wellness Program at Lucknow, and she will be the state guest at KGMU, and where she will be delivering a lecture. And I am also planning to have a ACP meeting around that, so that we can also welcome her on the ACP platform a day before of the KGMU lecture of her. So thank you, Dr. Vidya, one more time. And this has been a great meeting, great talk. We enjoyed it. Before I close it, I must tell Amit Gupta to say a few words.
Thank you, sir. And thank you, Dr. Vidya ma'am. And this session was really very, very informative. And I think it is the need of the hour. And I would like to inform you that under the leadership of our Governor, Dr. Anuj Maheshwari, sir, ACP India chapter has actually taken very big steps in the concept of mentorship. So that is why he created the entire ECP, and there are multiple ways he is trying to mentor so many people, and entire advisory council also. We have our Vice President, Dr. J.K. Sharma, Dr. Srinivas Murthy here. So I think particularly I have seen this governing council that they are mentoring a lot of young people. And I think in coming time, ACP India chapter is going to come up as a very, very robust chapter. Thank you for your guidance. And I think we all learned something from that. And how to nurture a relationship between a mentor and mentee was something, the message which you and Dr. Anuj sir has given to us. Thank you. Thank you, Dr.
In fact, it was not good only for the mentees. It was very good for the mentors also. You were given a lot of tips for the mentors too. And that is good for many of people, those who are senior and looking for the mentorship.
Thank you again for the opportunity, and it's been wonderful to meet you all. And congratulations, Dr. Maheshwari, on your continued, great work that you're doing. I know that you all know that Dr. Maheshwari's work led him to win the Evergreen Award last year at the ACP international meeting that we had. This year, I am looking forward to you winning more awards for all the excellent work that you're doing.
Thank you. Thank you.
Congratulations to all of you, and great leadership here that you're displaying.
Thank you, Dr. Vidya. Hope to see you.
Yeah.
And Dr. Srinivas Murthy is coming on the San Diego meeting. Dr. J.K. Sharma is also coming on the San Diego meeting. Dr. Sharma, would you like to say a few words before we close the program?
Yeah, thank you, Dr. Anuj, and thank you, Dr. Vidya, for a very, very wonderful session. It was all informative, as Dr. Anuj said, both for the mentors and the mentees. We have also learned many things. And of course, we all know that Dr. Anuj is doing the great work with all the council members, and this we will continue with. And we are also having one meeting, medicine update, on 1st and 2nd July, that will be physical in Delhi. And Dr. Amit Gupta is the joint organizing secretary for that. Under the leadership of Dr. Anuj Maheshwari, I'll be the organizing secretary. But you are coming in March, so I don't know whether you will be able to make it in July or not, 1st and 2nd July.
Yeah, thank you. We'll discuss with Dr. Vidya. Dr. Kamlakar Tripathi is being seen on the screen. Dr. Vidya, he is a very vibrant and very eminent member of our council, and he has been honored with the Padma Shri this year. So this is really a celebrity in our council. He is a celebrity of our council.
I was listening both of you, Dr. Maheshwari. I was listening both of you. A wonderful conversation, but I had my patients in between, so I never wanted to disturb you. Because some of the patients unfortunately become very little serious, so in between I had to stop it. Wonderful, as you rightly said, for the mentor and the mentee both. It's like inducting someone who is going to become the torchbearer like you, maybe Dr. Srinivasan. Vidya did a wonderful presentation. And Dr. Puri also did a great presentation, as usual, on lipid metabolism and gave a lot of clue. It's an important meeting. And we keep on learning. Even we become older, we learn a lot from younger people. And in the next generation, when we become mentor, then we will remember all these achievements. Wonderful. Thank you, Dr. Maheshwari, for wonderful conducting the meeting, organizing the meeting.
Thank you, sir. Thank you. So nice of you. So it's now time is over. So we shall take the leave from all of you. And thank you being with us. Thank you, Dr. Vidya, for being with us. And thank you all for being with us. We'll see you next month again in the ECP case file with a new case and new discussion. Thank you.
Thank you.
Thank you, sir. Thank you. Good night, everyone.
Thank you, Dr.
Thank you.
Bye-bye.
Thank you, sir. Thank you so much.
Congratulations, sir. Thank you.
Bye.